Hello everyone, welcome to our webinar on managing eczema flares and infections this evening. Thank you all for joining. Just going to allow another couple of minutes to let people join. Hi Julie, how are you doing?
Hello Eleanor, how are you? Hello everybody, thank you for joining. I hope you're going to find it useful and enjoy it, and we'll just wait for a few more people. There seems to be people pouring in at the moment.
Which is great to see. Welcome everyone if you've just joined. Going to give another few seconds to let anyone else join. Okie dokes. Oh, okay, I'm going to kick us off then, Julie. Well, welcome everyone. Thank you for joining our webinar from the Exploring Eczema webinar series today. We'll be learning about eczema flares and skin infections. I'm Eleanor Martin. I'm the Health Content Lead here at the National Eczema Society. And today I'm joined by Julie van Onselen, our lead speaker for our Exploring Eczema webinar series. National Eczema Society is a UK charity that provides support and advice for people affected by eczema. Alongside our wide range of information and advice, we use our collective voice to raise awareness of eczema, progress research, and campaign for better care. We've been working to make life better for those living with eczema for over 40 years and rely on voluntary donations to fund our work. We will be recording today's session, so you'll be able to watch back afterwards, but not to worry. All microphones will be muted and cameras will be off. If you don't wish for your name to appear in the recording, please change your name to anonymous. Yep, let me just my screen here. Excuse me. There will be an opportunity to ask questions throughout the presentation using the Q&A chat feature. I'll drop a line in there after I've done the intro here so you can see where to enter your questions. We'll aim to answer as many of these after Julie has finished her presentation. So feel free to submit them whenever. We do have more webinars coming up shortly, but I'll speak more about those at the end of the presentation. And without further ado, I'm going to hand over to our lead speaker, Julie, who Julie has worked with the National Eczema Society as a clinical nurse advisor for over 20 years, providing support to thousands of members of our community. And she also has an impressive 30 years of experience working within the NHS supporting those with eczema. Over to you, Julie.
Thank you, Eleanor, and good evening again, everybody. It's really lovely that you're all joining. I think Eleanor probably mentioned it, but just to say, please ask questions as you go along. There isn't an opportunity for live question and answer because, but what the opportunity is for you to type your questions in. Is that just into the Q&A or the chat box, Eleanor?
Yes, yep. I'll pop a prompt into the Q&A feature so you can all see where it is.
Lovely. Right, well, let's get going with this webinar, number 5 on managing eczema flares and infection, and the other webinars in the Exploring Eczema webinar series, which feature children's and babies, school-age children, emollients, and other topics will be on our website and on our YouTube channel. Eleanor mentioned that I'd work at the NES, which is a big part of my role. It's 1 day a week. But also I do work as I call myself a dermatology lecture practitioner because I do some clinical work and I do some teaching work. But I think for the purpose of this webinar and to reassure you is I have looked after people with eczema for over 30 years. And all those people I've looked after with eczema have been treated with topical steroids, which is one thing we're going to discuss today. So I do have quite a lot of clinical experience, which of course I would love to share with you. Absolutely recognizing that eczema is an incredibly individualized condition. And I do really appreciate that as well for you all. And I do hope this will be helpful. So what will my webinar cover tonight? We're focusing very much on when eczema is flaring. And I think this is a reason why there are so many of you here tonight, because eczema flare-ups are absolutely miserable. And you're always hoping another one won't come. But as I say to people, unfortunately, I describe eczema as being a little bit like the sea. The sea is unpredictable. You never know when it's going to be stormy or wavy. And then the sea will be big-armed. And then out of nowhere, a freak storm or a freak wave will flare up. And I think that really does sum up eczema. It is very difficult to sometimes predict, but we will talk about the causes of flare-ups. Now, eczema flare-ups may be just inflammatory flare-ups or acute eczema, but they can quite often be because of skin infection. So we will also talk about how to recognize skin infection. We'll talk about how to manage eczema flare-ups effectively, even how to try and prevent them as well, because that does come into it. And of course, prevention is often with emollient therapy, and flare treatment is usually with steroids. But we will also talk about topical calcineurin inhibitors as well. And we'll talk about how to treat skin infections. So lots to cover. So I used to work on the helpline for over 20 years, and I would speak to people every Monday on the phone constantly around the whole country. So as well as looking after my own patients in Oxford, where I live, I've also spoken to people around the whole country. And I think the main thing is the webinars have really been based on that experience and thinking when people have phoned, what have they actually been asking? And they often say, well, what does it mean, an eczema flare? But what causes my eczema to flare? Can I prevent it? What's the best way to treat it? And how do I recognize if it's actually infected? And how is skin infection treated? So covering those issues today, which I hope will be helpful. So I think when we talk about what causes a flare-up, and I've already given my analogy of eczema being rather like the sea, it often is just eczema flaring up. It's to do with eczema itself. And I think, the frequency does relate to the severity of eczema. And some of you may have quite severe eczema. You may have had it for many years, even all your life. And some of you may be new people to eczema, either a parent looking after a little one. I saw a lovely father today who was a parent of a 4-month-old baby with eczema. And, so the beginning of the journey. And so there's a whole variety for you. So the compromised skin barrier is really important to understand because 50% of all of you with eczema will actually have a compromised skin barrier due to a defect in a gene within your skin. And it's called the filaggrin defect. And what it means is that rather than your skin being a bit more like a very robust protective barrier, almost like a brick wall, and we've got a picture coming up soon, it's more like a dry, broken down brick wall, which actually means that these triggers, which are mainly as a cause of the flare, the triggers of allergens and irritants getting into the skin. So, certainly not treating the skin barrier is a big factor that can cause flare, because if the allergen irritants get in, they excite the things called the cytokines, which cause the inflammation. And of course, eczema is very itchy, and eczema itches, and then it's scratched, and then it's damaged, and then that opens up the skin barrier as well. And then skin infections stand aside, and they need to be recognized and treated because they will always cause eczema to flare. So we will talk a little bit about those infections. I think it's really, really important to understand when you have atopic eczema, it is a chronic disease that comes and goes, and often that's the eczema itself. And it's complex. It's really, really complex. And a lot of the complexity is because it actually is an autoimmune disease. So a lot of the complexity of the eczema flaring is actually due to do with the whole immunology of the skin, the reactions of T cells and B cells and regulation. And as I say, the increased allergen penetration through this compromised barrier. In addition, one problem with eczema getting infected is that people with eczema have 80% more Staph aureus within their skin, and Staph aureus basically is a bacteria that drives infection. So, there are lots of things that can contribute, and the complexity of eczema, I don't think can be underestimated. I think the problem is that a lot of people say, well, I want to stop these flares, I want to stop this eczema. And I actually say, it's complicated. It's a genetic disease. It has this very complex immunological basis, and there are many allergens and irritants that trigger your eczema. So back to the compromised skin barrier, what do I actually mean? So you can see if you have normal skin and you don't have eczema, and maybe if your child has eczema and they don't have the filaggrin gene, because the one thing we do know about this gene that disrupts the barrier is that you have it for life. And it's probably a clear factor why eczema continues through life. In fact, sometimes eczema might even get better in older childhood, in teenage years. And there are a lot of people who sometimes the eczema just comes back with a vengeance in their 20s. That's a really common pattern I've seen for 30 years. Eczema itself, and perhaps due to this skin barrier. So in normal skin, it's much more akin to a nice cement wall. These bricks relate to the corneocytes within the skin, and in normal skin, they sit in lovely, neat lines. They're surrounded by lipids, the lipid lamellae. It's a really robust structure, just like a newly cemented wall. Irritants and allergens can't get in, but most importantly, moisture can't be lost. And what happens again for 50% of you with this compromised barrier is that the corneocytes shrivel, they become uneven sizes, they can't hold this water. Holding water is really, really important because that makes it robust. And the lipid lamellae around it basically disintegrates. Now, this means that the skin then is dry because moisture is coming out of the skin. And because it's dry, it sort of spreads and cracks. And that means that these irritants can come in, hit this immunology in the skin, the cytokines, and that is what triggers the flare. So it's just really important to understand that, protecting your skin barrier and this is the science behind why emollients are absolutely essential and they need to be used every day. I normally say complete daily emollient therapy, so emollients for washing and moisturizing on an ongoing basis. But of course, I talked about the genetic basis, I've talked about the immunology, but of course, triggers are incredibly individual as well. And sometimes it's a trigger that will just trigger off the flare. Let's think of a really good example, and I'm sorry if some of you have suffered from this, but what happens in the spring when the blossom is on the trees and suddenly there's a lot in the atmosphere? A lot of people suddenly have a phase of having really bad skin, eyelid and eyelid eczema or around the eyes in that time of the year. And that simply is pollens. You're reacting to pollens. And in fact, most eczema triggers are irritants and individual, but some are allergies. And actually, if all of you listening today had an allergy test all at the same time, there'd be one thing that you would share in common. You would all be allergic to pollens and grasses, and you would all be allergic to house dust mite or their droppings. But obviously, you're not going to be allergic to hot, cold weather. You're generally not allergic to soaps and detergents. And you're probably not allergic to fabrics, but they are all irritants. So the thing is, you have to sort of get to know what's your irritant, how do you address it? And with pollens and dust mites, I always say hard to get rid of what's in the house and hard to avoid going outside the house. But obviously, in those times, you may have to predict your eczema might flare. If you're affected by, say, pollen in the spring and with things like dust mites, you have to do the best possible thing in the house to reduce them, such as hoovering, vacuum cleaning. Now, I will go through this fairly briefly because we did a whole webinar all about this and went into much more detail on all these topics. And that webinar was called Eczema Triggers, and that was webinar 4. So going back to flares, the subject of tonight, when your eczema has these cycles. So as well as being like the sea, it sometimes has a cycle which we call an acute cycle in medicine, which is when the eczema's flaring, so intensely itchy, red, sore. You or your child, you can't sleep. Your eczema's sore. It may be weepy, and I think that's an important thing to say that if your skin is weepy or slightly tiny little blisters, we call them vesicles, that's a sign of a flare. And then, you treat the flare, often a short-term treatment course, and your eczema goes quiet, and then it just becomes very dry. And the itch is still moderate, but, it's dry. And then your eczema flares up again, And as I say, the itch does continue through all the stages, and then it starts to become itchy again. So, itchy skin is scratched, it's broken, it becomes weepy, sore, and it's a whole vicious cycle. So a lot of treatments, particularly for flares, are trying to treat this cycle. Now, you may see that these pictures are all in white skin. Now, it's very important that we look at everybody's skin in our population, and certainly when eczema flares in skin of colour, it can be much more difficult to sort of detect the flare because inflammation in white skin is red. Inflammation in skin of colour is actually hyperpigmented. Now this little one here does have very severe eczema. Look at the dryness, and you can see, gross redness. And this teenage boy also has eczema, but the eczema is much more patchy, and it's more a mixture of what we call darkening of the skin, hyperpigmentation, or lightening of the skin, hypopigmentation, which relates more to resolving eczema. It can resolve in a hyperpigmented way, but generally it's hypo, and it may take several months for the skin to return to normal after a flare. So here's some hypopigmentation, and interesting enough, only seen on skin of colour, and obviously this does happen in white skin, but you can't see it. This is something called pityriasis alba, which is actually the most mildest form of eczema, often just using emollients. But the whole point is the skin change is a bit alarming. So it is really hard because it's another thing to deal with. If you have skin of colour, you've got to deal with skin colour changes, which we don't see as much sometimes, but not as much in white skin. So I've already talked about the real importance of applying emollients and using complete daily emollient therapy. And this is very embedded in the science of the skin. We know that if you use your emollient regularly and you repair the barrier, can you see, as opposed to the other slide, all these coniocytes are lining up in a row and the lipid lamellae is starting to restore around them. Probably not using moisturizers is the single worst thing to do, which will make your eczema continually flare. And, the moisturizers in their own way, as bland, simple treatments, actually can prevent flares. So you're repairing the skin barrier, you're relieving the itch. You need to find an emollient to suit you. One of our webinars was also on emollients. Lots of information in there about choice and ingredients, and it needs to be you or your child's preference as well. So as I say, the itch, scratch, damage cycle really does aggravate flares as well. So not just itching, rubbing as well with implements. So any rubbing also, and what the rubbing does is it stimulates these little cytokines over your skin. Sometimes it's really hard, and sometimes people feel an implement to rub with or a scratch actually gives them great pleasure because the itch goes away, but it's often replaced with pain. Now we're going to explore in the next webinar an awful lot about actually itch and different types of itch. So I'm going to save that for the next webinar. But the main thing is that any itching or rubbing leads to scratching, which actually results in more inflammatory mediators being released, which actually makes your skin redder. And this leads to the development of eczema and more dry skin. And then you have this vicious dry itch scratch cycle. Now, I really don't need to tell you about that because I know this is something you're going through. So I think it's really important that emollients will treat every stage of eczema as well. And as I say, these are your long-term continual treatments. So how are eczema flares treated? So I think I've already emphasized this, that emollients are your ongoing treatment. Environmental measures avoiding reducing triggers will help. And eczema flare treatments by our UK guidelines are first-line steroids. We'll also talk about the second line, the topical calcineurin inhibitors, but the emollients continue throughout the flares. You never stop the emollients. And also you need to recognise and treat skin infection, generally medicines needed, obviously in the form of antibiotics. So when you apply emollients, this is also really important because as I said, rubbing can actually, stimulate the cytokines. So it's really good to just have a really good method of applying where you dot the emollient on your arm, you stroke it down, covering the whole of your arm. And then it literally smooths in, often just leaving a thin film to just gently absorb. Now, if you rub emollient in, and most people do rub creams in because it's kind of almost a natural response, a rub will very quickly become a scratch. So just by changing the dots, your emollient application to a dot stroke smooth can actually almost be another method that can prevent a flare for some of you, perhaps with milder eczema. But if you rub, that can often actually cause a flare. So that's useful to know. So eczema flare treatments, topical creams or steroid ointments. So you have a choice. Often if you have very dry skin, ointments I feel are often better. They're only to be used once a day, so you don't have to have them sticky under clothes. But creams sometimes are certainly preferred for faces, even folds of skin, and sometimes genital eczema. Now, they are the first line treatment for eczema flares, and we'll see this when we actually look at our national guidelines. I think the first thing really I always love to say to people is that topical steroids have actually been around for 70 years. It seems amazing. And like anything in history, mistakes have been made. When they were first developed in the 50s, only the mildest steroid was available, hydrocortisone. And then the 60s, there was an explosion with the 4 strengths we have now. I'll go through that in a minute. Of course, this was terribly exciting because in the past, I don't know if any of you, perhaps we have some people who are older listening, if any of you actually remember what eczema treatment was like before steroids were invented or produced. Well, I have a friend in her 80s and she has really bad asthma. She's had bad asthma all her life. She probably has almost died several times because of her asthma. And her sister has really bad eczema. Her sister's eczema is much better now. She's an older woman, but as children, one asthma, one eczema. And my friend says to me, I'm so glad I had asthma. And I said, well, why? And she said, well, because my sister went through so much more with eczema. But she said, I was also aware that my asthma could actually kill me at any time, and eczema was never kill my sister. But my sister used to be hospitalized for 2 to 3 weeks at a time, put in a bed with, and because she was so red and itchy, her arms were literally tied to the cot side, and she was sort of fed with a spoon. It's a horrible, horrible image, and of course that wouldn't happen now. But I think the main thing is there wasn't anything to control this inflammation, and now we have so much choice from steroids to topical calcineurin inhibitors. And it's so exciting. The explosion of the advanced therapy treatments with the new biologics and JAK inhibitors that are targeting that complex immune system is just phenomenal. I am bowled over with it myself. The choice there is there. Now, I think the other thing is, which is different, is that there were mistakes made. This whole revolution of steroids came, and babies and children with bad eczema suddenly didn't have to go into hospital and have this barbaric treatment. They could be treated with a cream that cleared it up. And of course, they were overused because people didn't know. It was the 60s, a long time ago. And they were given too much and they were wrapped in cling film. We would never, ever, ever do that now. But mistakes were made. And then in the 70s, mistakes were realized. And then in the 70s and 80s, it went completely the other way. And people actually didn't want to use steroids because they felt they would damage the skin because that's what they'd seen. Now, hand on heart, I've seen skin damage from steroids in 30 years, or literally on 2 hands with people who've used too much. Now rolling on into this century and this particular moment in time, and certainly in the last few years, there has been an explosion in worry of topical steroid withdrawal, which I'm going to talk about on the next slide. This is quite new to me as well, but in terms of how it's progressed, because it was not thought of at all until quite recently. But I think the main thing is the principles, and then we'll talk about it. So topical steroids can be applied to broken skin. The instructions for steroids are generic, but active eczema is often broken because of the scratching. I think you know that. Only apply topical steroids to areas of active eczema, which has been active in the past 48 hours. So you apply it to the red bits. And the general rule is to only use topical steroids for short treatment periods, up to about 14 days, although we can continue with a maintenance for stubborn eczema. We call this weekend therapy, so 2 consecutive days a week for up to 8 weeks. If you follow these rules, you're unlikely to go wrong. Now, steroids should only be applied once a day. You may even need to teach your healthcare professional this. There's a lot of confusion with healthcare professionals because dermatology training is really probably not good enough, particularly for people working in primary care, and not long enough. So you don't need to apply 2 to 3 times a day, just once a day. And that's a really good way to really rationalize how you use them. There's been some really good scientific studies comparing different amounts of application, and once a day is certainly the guidance. The other thing to remember is we get information from across the water, and we get very good information from across the water in the US. But in the US, treatments are different. There are actually 7 potencies of topical steroids in the US. There are steroids that are much stronger than the UK. So sometimes things you read, because with our world sort of becoming smaller and how wonderful we can share experience through the whole world. But sometimes you have to remember healthcare systems and guidance are very different in different parts of the world as well. So I am going to talk about topical steroid withdrawal because it's very important, first and foremost. The problem is that there's basically a whole medical evidence, which actually is quite poor. We definitely need research. And of course, there is an explosion of people sharing their experience out there, which is also very valuable. But I think the facts are that topical steroid withdrawal, there is no clear diagnostic criteria. We think it possibly could be a known side effect, but it would be really using high potency or strong, very strong steroids for long periods of time, not for short bursts. And the majority of self-reported symptoms, it's very hard because poorly controlled eczema actually has exactly the same symptoms. We do think it is a distinct category, but we do believe it is quite rare. There are some other names for it, but they tend to be patient terminology. So the generic term for everybody probably should be withdrawal. Now, as I say, we've got to discover this criteria, and I am working at the moment in a national party, which is a lovely group because it contains patients as well as clinicians. We're trying to get some criteria of diagnostics. But I think generally, there are lots of questions. We have a wonderful joint statement on our NES website on topical steroid withdrawal. So if you want to know more, please look at that. Severe eczema, which does not respond to topical steroid, does need to be referred to dermatology and have advanced treatments. Now, I know this from my years' experience that there's so many people and the steroids just don't seem to work anymore. It's because eczema is severe. Eczema is a little bit, you have to compare it maybe to asthma, but you could compare it to other chronic conditions such as arthritis or ulcerative colitis or something like that, where you have to sort of, you have varying degrees of chronic illness. So the different degrees need different treatments at different times. Now, to minimize topical side effects, I keep this really quite simple. And really, and again, this is very much from my years of experience, the problems I've seen have always been caused by too much, too strong, too long. So to minimize these risks, healthcare professionals prescribing steroids should control the potency or the strength, and we prefer to use strength in lay terms because it's easier to understand, the quantity, the amount you use, the frequency, how much you use it, and the duration, how long. Now, if you get really clear advice on this, and I should say in the Eczema Society, we have a super fact sheet as well as the TSW FAQs. We have a wonderful fact sheet, which is literally all about basically topical steroids and their common use and how to use them effectively in children and adults. So as well as having these trying to reduce risks, we have to match the topical steroids we prescribe to the age of the child, the severity of the flare, and the body area. So sometimes it can be a little bit confusing for you because unlike an emollient, one emollient can often fit all. A topical steroid, you may have different steroids for your face, your body, and even your hands and feet. And of course, it depends on the severity of the flare. So basically, if a baby has eczema, you generally would use a mild hydrocortisone. But if the baby's eczema was more severe and it wasn't resolving, it's possible a Humavate may be used for a short time to reduce down to a mild. Now, if you have a toddler or a child with really quite severe eczema, you're not getting on top of it, your poor little child just is scratching all the time, you are absolutely distressed, none of the family is sleeping, please, please don't worry about a short burst of a strong steroid, because actually that will just get the eczema back in control. So you may be prescribed a strong steroid for a child, it may worry you, but actually for a short 2-week burst, once a day for 7 days, then every other day for a week, it's the only treatment really that is going to control that flare. Now, if you have really bad hand or foot eczema, we're actually going to have a webinar on hand eczema in March. The skin is much thicker, so you're going to have to use a steroid that is stronger, and that's when we may use the very strongest. It's quite rare to prescribe the very strongest, actually, in UK primary care, and it's often prescribed by dermatologists. So this is sort of, the first 3 groups. And as I say, remember, in other countries, they actually have more groups of much stronger steroids. So you can't necessarily compare country to country. Now, faces for everyone, we would keep that low. We would keep it to moderate for adults, mild for children, and we would try and move people off steroids as quickly as possible with the face, because we do know that actually the face has the thinnest skin, particularly the eyelids. So we do have another really good treatment, which is non-steroidal, which we can use for the face. So that just gives you a little bit of an idea of how somebody who is working with people with eczema, who's prescribing, who's advising, would advise and prescribe in the most appropriate fashion. And that's what healthcare professionals do. They prescribe steroids because they want to individualize the care and do the best for the patient. Now, quantity of steroids, how much we put on, is very important. There has been so much confusion, and the term used sparingly is still bandied around. But did you know that terminology was taken out of the British National Formulary in 2012, the year of the Olympics, remember? So basically, use sparingly to most people meant to use the tiniest tip on the end of a finger and spread it as widely as possible around the body. They used the steroids, maybe they did use them for a week or 2. They used the tiniest amount and the eczema didn't go away, and then the eczema came back. Oh, it's the steroids' fault. In that case, absolutely not. The eczema hasn't been treated. So the fingertip unit's really important. So you may be surprised, 2 hands, eczema on your wrist, eczema here, both sides. You need 1 fingertip once a day, 1 fingertip once a day. Now that you may then need, 3 or 4 for the legs. You may need the same for the trunk. So you may actually need for a treatment of eczema, you may need sort of 30 to 50 grams, which is not absolutely too much at all. It's the right amount. It's much better to treat the eczema with a short, sharp treatment. And basically this, it's a bit like being prescribed an antibiotic. You wouldn't say, I worry about an antibiotic rebounding my infection, so I'll cut the tablet into 8 and just take an 1/8. So it's the same with steroids. They are a drug and they do have side effects. But actually, if you ever read the side effect profile for paracetamol, none of us would ever take it. We'd all think we were going to get liver failure. But in effect, this is the dose. So you think of it almost like it is the dose because it's a medicine and it needs to be treated with the greatest respect. Now, control of frequency is important because actually the most important message here is you only need to use steroids once a day. Now, if you're using them twice a day and your flares just stop to once a day, you're using half as much. That's a really good way to reduce, duration and not use too much. It's a good idea to get into a bedtime routine. We talk about this in other webinars. Apply in the evening after you've had a daily emollient bath or shower. I cannot stress how important washing daily is with emollient. So don't use plain water because actually that has got a higher pH than if you add emollient to water. So you come out a tepid, so a lukewarm bath, not too strong, not too hot. And then you apply the topical steroid to the red area in your fingertip units. Excuse me, wait 20-30 minutes and apply emollient. Apply it thinly or in fingertip units, but not sparingly. And as I say, ointments are perhaps better for dry skin. Excuse me. So I think, this is from a colleague of mine who's a very eminent pediatric dermatologist, and she talks about getting control of topical steroids for 2 weeks, keeping control, stepping down. So either sort of every other day, but the weekend therapy 2 days a week is often recommended. And then ongoing control is with your emollient. Now, the possible side effects are absolutely there. Risk of thinning and striatal stretch marks is still there. Systemic absorption, I can honestly say hand in heart, I've seen twice in 30 years. And we've already talked about TSW. Sorry, excuse me. It's
Okay,
awful
Julie,
when
you
you're
take
trying
a
to
couple of
you're
seconds
trying
there.
to swallow a cough.
No, it's the worst.
Sorry.
No,
So
take
these are why
your
the
time.
problems are caused: too much, too strong, too long. Now, I think the other really important point that we never really hear is that if eczema is undertreated with topical steroids and the flare isn't treated and it's very red, the skin barrier function actually gets worse and the eczema gets worse. So again, that is science. So that's what happens. Now, guidance, and I'm just going to read out some of the guidance because this just proves that, NICE and SIGN are very eminent. Lots of experts gather to really discuss, what the best treatments are for lots and lots of things. And again, based on evidence. So they do say, you must discuss benefits and harm. You should do that with any treatment you offer any patient for anything, and emphasize the benefits often outweigh the harms when applied correctly. Only apply to active areas of eczema or broken skin. Continue with emollients during the treatment with topical steroids, and patients should apply once daily. So it's just quite nice for you to see what's in the guidance. Now, the alternative to topical steroids are the topical calcineurin inhibitors. So some of you may have already been prescribed these. So worth going through this because actually these are fantastic. I have a theme where I talk about eczema being a talk. When you have eczema, you need a toolkit. You need your emollients. You may have more than one for washing and moisturizing. You have a range of topical steroids that you're applying to your eczema, depending on where it is severity or the age of your child. And then the steroids are generally used to treat the acute eczema. So what you need is you actually need another treatment often for the maintenance. So I often say the eczema when it's very fiery is like a fire. So you need the right fire extinguisher. Now, when you put that fire out after 2 weeks treatment, generally, the eczema is settled, hopefully, and has moved to dry skin. So you just go back to emollients. But if it's still sort of wavering a bit, and if it might be sort of slightly pinky, I call that the embers. So that's why we would use the weekend therapy, because if you leave the embers and they're still active, the eczema will bounce back. So a lot of people talk about steroid rebound, which is certainly a phenomenon. I'm not saying it doesn't happen, but actually it's highly more likely to actually be eczema rebound because eczema is a chronic condition. So the thing is, you've got to treat the pink skin and the embers. And topical calcineurin inhibitors work on the eczema immune path. So they have a different action to steroids, but they still act in a very positive way. They're not quite as efficient for very fiery skin, and so you do need to put out the fire with steroids which are anti-inflammatory. But the key thing is they can be prescribed, and there are two types. There's tacrolimus and pincrolimus, Protopic and Elidel. And the important thing to remember is that Elidel is actually licensed now for 3 months of age onwards. So if you have a baby with really bad eczema, you're not getting on top. Remembering eczema will always go completely out of control when babies are teething, and sometimes you just have to work through that period. And you don't want to keep using hydrocortisone in short bursts to control it. You can actually ask your clinicians to prescribe you something that isn't a steroid for your baby's face, and you can ask for Elidel. You can have Protopic from 2 years or a stronger version from 16. But the thing is, they are underprescribed, these treatments, and they are so useful in the maintenance. They actually can be used twice a day for up to 6 weeks, and then long term as maintenance therapy on 2 days a week as well. Weekend therapy with steroid is 2 days consecutively. Weekend maintenance with TCIs is a sort of with days in between. So say Monday, Thursday, Tuesday, Saturday. The main side effect is burning and irritation and an increased risk of skin infection. So you shouldn't use them if you feel your skin is becoming infected. They don't cause any skin thinning at all. I will move people with facial eczema onto these very quickly. I will always use TCIs for eyelid eczema. That is just my practice because I do know that the risk benefit is much better for that area. So if you haven't heard of them, we have a fact sheet called topical calcineurin inhibitors. If your GP or in primary care says they can't prescribe them, they absolutely can, because actually they can be prescribed by any healthcare professional who manages eczema, and that's everybody in primary care. As I've said all this really, and they can be used as an alternative treatment. To be honest, in the guidelines, they are actually classed as second line, but actually there is very much a place for first line, particularly on the face and the eyelids. Here's some nice guidance again from NICE and from Sign, and they again they do say second line. They talk about using them very much for facial eczema. I wouldn't call them a step up from steroids at all. In fact, I have another slide that I teach healthcare professionals, and I see them as a side-by-side treatment, but I see them very much as the longer term eczema treatment and steroids as a shorter term. So certainly, they are very useful, particularly if there are risks of the side effect of atrophy or maybe skin thinning, as sometimes can be with steroids with long term. So moving to infection, I think if eczema is getting worse or in skin of colour, we might say darker rather than redder, itchier, and topical treatments just simply aren't working, always think infection. So there are two types of infection, bacterial and viral. Viral infection I'll start with first of all, because actually you need to know how to recognise this. It would happen to your child perhaps never, in fact often never, but it is often appears when a child has a contact with a cold sore. So it basically is an explosion with eczema on first contact with the herpes virus, the HSV virus. And basically, the eczema will literally explode overnight. It will become what we call it vesicular, these little watery vistas. It often starts around the face. It can be in other parts of the body. The key thing is it will be painful. So a child who rubs their face with eczema, they will actually be holding their hands up. They know they've got eczema, but they daren't touch it. It's painful. They'll be unwell. They'll have a temperature. They won't be well. And the eczema will be much more of a blistered form. So if this does happen, you need to just take the child basically straight to A&E and get immediate help, because they will need an antiviral drug called acyclovir to get rid of it. And you have to treat this because it could become actually dangerous if you don't. A bacterial infection is when the eczema just becomes very crusty. So it's weepy, but it has yellow golden crusts and the eczema is inflamed. The child will feel unwell and have a temperature. So in infection, you generally get children feeling unwell. It's not responding to topical corticosteroids. So an urgent appointment with your GP. children and adults with infections will generally need oral antibiotics. Occasionally, we can use a topical antibiotic or a combined topical antibiotic with steroids on a patch. Topical steroids continue because the antibiotics are treating the infection, but the eczema is still flared. So you don't stop the topical steroids, you continue them alongside. And this is a case where the emollients which have the antimicrobial ingredients are pretty useful because the antimicrobial ingredients will actually help cut down the Staph aureus on the skin. And of course, bacterial infection is so common because of the scratching and damage, but also you may remember I said earlier, 80% more Staph aureus on the eczematous skin, so much more chance of infection. And again, if you don't treat your eczema, don't treat the skin barrier and stop your eczema treatments, you're probably more likely to get infected. So I think it's always worth talking about chickenpox because there's people on this webinar with children and people really worried about chickenpox. They think, my God, if they've got eczema and they get chickenpox, it's actually going to be awful. And sometimes people shield their children. So I think the first thing I'd say is do not shield your children from chickenpox. Just get them to get chickenpox as early as possible. Of course, there are vaccines, but they are not in the national vaccination program. So that could be your choice. But the main thing is they wouldn't be necessarily recommended. So the interesting thing is with this really clever immune system is that when you have chickenpox and it's active, and this is active chickenpox when it's very itchy, slightly vesicular, a small blister, and red and slightly maybe a bit watery, the eczema around it actually almost clears up. Eczema goes quiet when chickenpox active because the immune system has this clever switch, and rather the bits of the immune system that have been driving the eczema, they just switch to attacking and getting rid of the chickenpox because the immune system is incredibly complicated, but it's also incredibly clever. Now, when the chickenpox has resolved after sort of a week to 10 days and it crusts over, the problem is that eczema can sometimes come back with a vengeance. Often because the skin's been a bit rubbed or scratched, often because even treatments used can cause a problem. So, top tip, do not use calamine lotion. It's chalk, it's dry, and all it will do is dry out the skin. So it might relieve the chickenpox, but it will be drying up the skin to make the eczema worse. So just use your child's moisturizers if they have chickenpox and maybe keep them in the fridge. Don't use topical steroids or topical calcineurase when chickenpox is active because you've just got to work through the chickenpox and you don't want to use steroids on chickenpox because the chickenpox has to work through. And you wouldn't use a TCI, topical calcineurase inhibitor, in infection as well. So I thought it was just worth going through the common infections, and I've always had lots of questions about chickenpox and lots of worries, and hopefully that sort of reassures you if your child hasn't had chickenpox as yet, and hopefully you'll recognize that as well. So hopefully that's all been good advice. I have come to the end. This is a slightly longer webinar than normal, but actually we have got a good 10 minutes for questions. So we may finish earlier if there aren't so many questions, but we can run through from the next 10 minutes and answer all the questions that you may have. And I'm very sorry about my coughing in the middle. I couldn't stop it.
Not at all. Happens to all of us. No, you did a brilliant job telling us all about how to manage our eczema flares and skin infections. I'm going to go straight into the questions as we've had quite a few. But to start us off, we've had a question that says, does topical steroids require a prescription? Could you tell us how to safely access topical steroids, please?
That's such a good question, isn't it? Thank you for asking it. Sometimes you don't say the obvious, and it's lovely. So lots of obvious questions, please. Yes, there's two parts to this. So if you've got a child or even an adult who's developed eczema for the very first time, you need a diagnosis. So basically, a lot of it's to do with pharmacists' rules. So pharmacists cannot prescribe. If you've had eczema before, you can buy, and this actually is a very good argument for why topical steroids must be have a safety profile. You can only buy the two mildest forms, or the least strong ones, so hydrocortisone or Umivate. But pharmacists have rules, so they wouldn't sell Umivate for a child, but they would for an adult. Now, the slight problem is they come in tiny tubes. They come in 15-gram tubes. So it probably is best that you get your topical steroids on prescription. And of course, the other reason is it's a good idea if you have eczema that your healthcare professional also monitors you. But also, if you're quite expert at your eczema treatment and you have this toolbox and you want to have a range of treatments because you yourself will recognize and treat your flares at your earliest point, that's great. So you could also ask for those treatments on a repeat prescription as well. So there's a few parts to that, but I would say essentially they are prescribed because you need to be assessed. Yeah.
Thank you. Can people with open sores apply emollients?
Yes, absolutely. Open sores. Well, sores is always an interesting word, isn't it? It's a quite an old-fashioned word, actually. Yeah, and open sores. I mean, the thing is, obviously, you have to be aware what the sore is, but emollients can be applied to any active skin. If it's eczema, so can topical steroids. But of course, you have to just watch, your child, open sore. Is often seen in something like impetigo, which of course is an infection. But yes, emollients, absolutely, there's no problem with them at all.
Brilliant. We've had a question from someone. You referenced using cling film in a treatment earlier in your talk, and they've said, I was advised to wrap my foot in cling film after applying Elicon. Was that wrong?
No, it wasn't wrong. I gave that example as babies and how you would never, ever, ever wrap a baby in cling film. Of course, we wouldn't. But I think if you had really bad irritating foot eczema, and I think in some ways what I can imagine is your prescriber perhaps felt they wanted to prescribe you the most strongest steroid, Dermavate, but felt it might be better to start with a potent one or the less strong, a strong one rather than a very strong. We're trying to use the word strong now in lay terminology, because they would be prescribing a steroid that wasn't as strong. But as soon as you put, and this is quite an important point, as soon as you put occlusion on, which would be cling film or wet wraps or bandages, you can slightly increase the strength of the steroid. So I would imagine they were doing that. And also, if you've got foot eczema or hand eczema, it is incredibly stubborn and you've got to keep it in place. And you imagine walking around or using your hands, the steroid would just rub off so quickly. So actually, for your particular case, I would say that your advice was probably very good. You often need to use steroids a bit longer on hands and feet. You feel your own hands, particularly as an adult, it's very thick skin actually. It's sort of 80% thicker than your eyelids. So that's why, we have to match the steroid to the part of the body and the severity.
Brilliant. When skin is infected, should you apply topical steroids, topical calcineurin inhibitors, sorry, or emollients? What should you avoid applying, if anything?
Only TCIs, that's the short answer. You carry on with your emollients, you carry on with your steroids, because the inflamed eczema will still be inflamed. Basically, if eczema is infected, the steroids won't work because the infection needs to be treated as well. But when eczema is infected, you've still got the inflammation because it's part of acute flare, but you wouldn't use a TCI. Remember, the TCIs are more for pink, uninfected skin, and there is certainly a caution about not using them with infection. So, yeah.
Brilliant. This next one is a bit of a long one, but I think it's quite important we talk about it because it references not using enough steroid to adequately treat eczema, leading to people believing they have topical steroid withdrawal instead. So
Yeah,
bear
sure.
with me whilst I read this. So it says, parent of a 10-year-old boy. He's had eczema since birth. I've been asking for a referral to dermatology for over a year. 2 weeks ago, we saw a GP and it transpired that my son was being treated with a mild eczema instead of moderate to severe. We have a very thick emollient, 2 weeks of strong steroid, and a maintenance steroid for afterwards. The emollient is very thick, which I don't think my son will tolerate. He's only tolerating it now due to the severity of his eczema. What's the best way to approach this? We thought he had TSW, but believe now that the flare wasn't controlled as the steroid was too low to fully treat the eczema.
Yes, no, it's a lovely case study, and thank you so much for sharing it. And I really sincerely hope your son gets better soon. I think that's really sensible because, of course, we absolutely acknowledge topical steroid withdrawal, but there is so much on the internet. I think when you type in topical steroids and people are sharing their stories, which actually is wonderful. I think it's really good to share. But the problem is everybody thinks then that if the eczema isn't being controlled, it must be TSW. And I think you always have to think and unpick it because your case is brilliant because a mild steroid in a 10-year-old boy with worsening eczema, not going to treat the eczema. It's too mild. It really is what it says on the tin. So the potent steroid actually is the right treatment. And it sounds like you've been given a good treatment regime. I think with emollients, and please go back and watch the emollient webinar because I think it will help. The choice is really important. So obviously, it might be that you need to have two emollients, maybe a greasier one at night, because obviously it is messy. And when your boy is 10, he doesn't want to. I always say you don't want to go to school like a channel swimmer, do you, to the children? And they nod and say, "Oh, can you give me a cream that's nicer for school?" Of course I will. So have a look at our emollient fact sheet. So it might be that, you've got the right regime with the steroid, but if the emollient's not quite right, and of course you want to use the steroid for the short time and after the maintenance, you want to stop it. So you do need an emollient that your son can keep using to prevent the flare. So I would say look perhaps for a humectant cream. They're a bit more sophisticated and they're very good at repairing the skin barrier. But the nice thing is they last a good 8 hours, so it would last through his school day. So sometimes, you've got the right treatment for the flare, but you also have to look at your toolbox and also look around about what you can do in terms of, the ongoing first line treatment of emollient. But yeah, hopefully that's answered it. And I'm sorry it's a little bit long answer. Always is hard when it's an individual case.
No, that's brilliant. Thank you so much, Julie. We have another question here. When the skin is dry and no amount of moisturizer seems to help improve it, should you use steroids, even if it's not red and active? It's the only thing that seems to bring my skin back to more of a normal.
Well, if it's just simply very, very dry and it's not red and it's not intensely itchy, it might just be that, the emollient is not the right one for you. I mean, sometimes people feel that they shouldn't have daily baths or shower with lots of emollient. And to have a bath with emollient, you should apply your emollient all over you before you get in the bath. And that can really make a big difference. Again, you might need a greasier ointment at night or maybe a humectant cream in the day. So it might be that if you've been provided with a simple occlusive emollient, I'm going into the emollient lecture now. Generally, a simple emollient will only last 2 hours, but you don't want to apply emollient for every 2 hours. So therefore, a humectant emollient will last 8 hours. So I think there's a really big wide choice. I would recommend you read our emollient fact sheet. But if it is itchy or red, or you feel it's sort of a sort of more it's not completely acute and red. Again, if you want a treatment, I probably would say ask for a TCI actually. Remember, they're good for the pink eczema, or C. I mean, the only other thing is, do you have a skin condition that sometimes can go alongside eczema called ichthyosis? And that is another topic, really. But sometimes ichthyosis can just cause very dry skin. So has your eczema maybe even been misdiagnosed? Again, a few things for you to think about and possibly unpick. Thank you.
Brilliant. Thank you very much. We've just had one in. My biggest problem is the itching. Would an antihistamine work at all to minimize the itching?
Great question. Itching relates to active eczema. So I'm not sure if it really depends how you're treating your eczema. Now, you saw how complicated the immune system was, and a tiny little speck at the bottom was the histamine. So histamine does not dominate itch in eczema. It dominates itch in urticaria. It dominates hay fever. So a non-sedating antihistamine actually will not actually help the itch. there might be a psychosomatic feeling that you're getting a tablet and it might help. If it's at night, a sedating antihistamine will help, but more for sedation. So generally, antihistamines are not that useful with the itch of eczema. It really is all about the skin barrier. So again, addressing your emollient regime might be a better thing to do. And also remember, you should be using 500 grams of emollient a week as well if you've got very dry eczema or very itchy eczema, and that's quite a lot. And most people don't use nearly as enough emollient, complete emollient therapy for washing and moisturizing.
Brilliant. And we're going to finish on a question. Sorry, just scrolling back to find it here. What precautions should wet workers take to prevent flare-ups?
Oh, that's a great question. Do you know what? We're gonna talk about that for a whole webinar almost. Not quite. We're going to have a webinar on hand dermatitis, and we're going to talk about irritant dermatitis, which often is something that wet workers suffer from in that way. Protective clothing, first and foremost, lots of emollient when you're not working, and even cotton gloves at night with lots of emollient to sort of give your hands a moisture service, surge and recovery. When you're at work, don't use the harsh soap or detergents in the sort of restroom area, and maybe just take your emollient in a little pot. We have again another wonderful fact sheet on hand dermatitis, so you might like to have a look at that as well. There are quite a lot of good tips there.
Okay, fantastic. Thank you, Julie. Just say Sharon, who has just asked, is it possible to get a copy of the slides? Yes, we will be sharing a recording of this within the next week. So there'll be a video format so you can see all the information from the slides and hear what Julie's had to say as a watch again version. So we'll be sharing that on our YouTube, and it will be on our website too. So we'll post a post on social media to let everyone know when it's ready to watch. But thank you for that question. Well, brilliant. I think that wraps us up for today. Thank you so much, Julie, for, as always, an incredibly interesting and informative talk. Yeah, I think managing your eczema can be incredibly difficult at times, and never mind when you're in a state of flare. But we hope our information today has been useful and has provided some additional guidance to help you self-manage your eczema. We do have a number of downloadable fact sheets available on our website, which is eczema.org, to support you through your eczema management. And I wanted to let you know we will be featuring a number of topics throughout our Exploring Eczema webinar series. Julie has referenced that we have a few upcoming ones, but the next one will be on itching and scratching. These will be on Monday the 10th and Wednesday the 12th of February. Registration is now live for those on our website, so if you head to our webinar webpage, you can find information about how to register there, information about other upcoming topics, and the recordings from our previous sessions if you missed those. But thank you again for joining today. We've had a brilliant session and lots of fantastic questions, so thank you all for being so engaged, and we look forward to hosting you next time. Thank you very
Yes,
much,
thank you,
Julie.
everybody. I really hope it did help you as well. And good luck, everyone, with everything. Yeah, keep in touch. Lovely. Take
Thank
care.
you, Julie.
Bye.
Bye now.
Bye.